thank you so much for your presentation. And of course, now it's time for you to make questions or maybe to challenge some of the results that have been presented. Please, can you identify yourself and where are you from?
Thank you for the presentations. I'm Olga, a Hungarian dietitian. And I would like to ask Professor Correia, if I pronounce it well. You mentioned about ideal body weight for overweight and obese patients. Would you use it for underweight patients as well?
Connected? Okay. No, we use actual weight for every patient except for those I've mentioned. Why? Because we believe that during the period of illness is not a time for them to put on weight. Actually, this is a high risk factor for adverse events, starting from refeeding syndrome and so on. So we use the current weight for all of the patients except those two.
Thank you. Just a second quick one. Ideal body weight, how would you define that, because there are differences in that as well?
It's the only time I use BMI because, by the way, I've already written the Reckon to BMI together with Professor Gonzalez and Professor Heimsfield. I hate BMI, but it's the only time I use BMI is to consider what would be the ideal within the time within the weight frame of 25 to 30, and then for the super obese we start cutting. But I have to agree that this is definitely not ideal, but that's what we have.
Thank you very much.
Oh, yes, please.
Thank you. Giles Major from Switzerland. Thank you. That was a lovely spectrum of presentations, and I love the idea about being more precise with the sort of protein that we use. I wanted to ask about the plant-based diet, because I think there's still a question about bioaccessibility of proteins and amino acids from natural plant foods, and whether you think that's a factor in some of the medical effects that we observe.
I'll take that one. So if we're talking about plants as food and not processed or anything, then you've got issues with digestibility, and that lowers the bioavailability of amino acids, and the essential amino acid profile is not as good as animal protein. So you have those two things to contend with. As soon as you isolate the protein and take away digestibility is an issue, we found, and if you saw me speak yesterday, most of the work coming from Luc van Loon's lab would suggest that the difference becomes much, much closer. And then you have strategies around protein complementation. You can increase or fortify with lysine or leucine if you want. And you can make things very equivalent. In the long term, we find that those differences that we think are such a big deal. So I've changed my mind on this, and that's how science works. I know it upsets people. 20 years ago, I would have said, oh yeah, animal protein, no problem. 10 years ago, I'm like, okay. Now I'm like, I'm not so sure. I think it's difficult when you're making choices with food. You have to be quite judicious about how you pick your food. But when you get protein isolated, or it really becomes the differences are smaller. So I think that there are opportunities to innovate with plant protein engines that would be different than I would tell you 10 years ago.
Argument for processing, okay.
Well, I'll say this. Look, we do diet analysis, and if you use all of the, whatever scoring system you use for ultra-processed foods, the young people that have the highest ultra-processed food intake are plant-based and vegans because of the foods that they eat. Sorry. It's just the reality, because they're contrived foods, right? They're eating burgers and drinking milk that is made from ingredients.
But good for their protein intake.
No problem.
Well, talking about nutritional epidemiology, probably you know that it's quite recent, has been greatly challenged because there is a nice paper, Grilled the Data. I invite all you to look at and study the statistical behind this, that we can easily show that depending on what do you want to demonstrate, the same data can help you to demonstrate that red meat kills or red meat extends your life. So unfortunately, and still as far, we need more precise way of developing nutritional epidemiology. Would support.
It's a great paper. That's an interesting paper, yeah, for sure.
Any other question? Yes.
Yes, thank you for this nice session and all the work that you have done. I'm Hanna Lislep. I'm a clinician and trying to find out the best strategy to consult our patients. So the tailored consultation and the cost of it is my concern. And for Professor Schuetz, I think I will ask this question: what is the rate of consultation? Because it's, as it seems, very important of who consults the patient with what competence. So what is in this study, effort study, and what you probably do count the cost there as well?
Yeah, thank you very much for this question. I think it's important to have the whole team in helping you. So in the effort study, we had the nurses doing the initial screening for patients, and then we had dietitians assessing patients regarding nutritional goals. And so we calculated that maybe for the first assessment, you would need about 30 to 45 minutes. And then dietitians would go every other day to see the patients. Some patients were going, easy. They would meet their goals, and there was not much time to spend. And other patients needed more time. And of course, the dietitians also have a very good connection to the hospital kitchen, and they can just help the whole team. So I think the dietitians take a very strong part, leadership part, but also it's about the nurses, about the physicians. So I think it's the whole team that needs to be engaged.
What about the effort 2? What is the consultation rate there?
Yeah, so for the effort 2 study, we also have at discharge, we have an assessment of the patient, and then we have about every 2 weeks, we have a follow-up of the patients. But again, it's similar for patients, where you see they have troubles meeting their goals, you have to do earlier follow-ups, and for patients that are going well, you can expand a little bit the time frame.
Thank you.
Thank you.
Maybe if I could, sorry, go. You go.
Okay.
No, you go.
I would just like to add one comment on the top of this. I mean, especially coming from poor countries where that is a big issue, Brazil is an example, we have to start showing through cost effectiveness studies that nutrition does work, and then when you pay for those professionals like dietitians, nurses, you're not really spending money, but you're saving money. There are, up to now, few but good data showing that. And in Brazil, we have used some of these data, some from our own studies in Brazil, showing that nutrition does not cost. Nutrition is an investment. Unfortunately, we are not so much used to using these as economists do, but we have to start learning and using cost effectiveness analysis, which, by the way, is not only money, it's quality of life and a bunch of other variables. So, of course, if the patient dies, it's not going to cost. But what about the cost to the others who survive, the family, who do not produce as much because they are grieving the departure of a dear one, and so on. So I think the problem or the issue is bigger, but we really have to start talking about cost-effectiveness analysis.
I have nothing more to say. That perfect.
Thank you.
Gülistan.
Hello, this is Gülistan Bahat from Istanbul University, and I'm a geriatrician, and I know you very well, all of you, of course. I would like to follow up the first question, adjusting the need for calorie energy for overweight and obese people according to the ideal body weight. But I would question it for the older adults, because we know that overweight is better for older adults, and we question if we should lose weight for the older adults.
Good question. So BMI for older adults is also different, and we take that into consideration. But as I say to my students, is you start from something, But what is going to define what you're going to do is how the patient goes. So I start from calculating based on this, but if the patient is still losing, and not only weight, because weight is one variable, but other indirect measures of nutritional status, such as functionality or even anthropometry, because that's what we have in our everyday routine, then I change. I mean, I either add up. Then on the other hand, if I have started from something and the patient is doing hyperglycemia, if the patient has side effects such as nausea, so you adapt. And that's why nutritional therapy, and this is my conversation with Philip, because one day I challenged him with an nutritional support. I think it's therapy. You do not just do the first planning. You have to follow the patient similarly to what you do with antibiotics. We, as doctors, start with one antibiotic, and if the patient is not doing well, we do other tests and we change the antibiotic. So nutritional therapy is a specialty or subspecialty that has to be done by those who understand nutrition. Not every, actually physicians do not know nutrition at all because they do not learn it in school. Here we are biased because we are a group of people that has been trained. The majority of doctors are not. And that's why it is so important to work with an interdisciplinary team, because if you do not know, you're gonna ask help. So I think it's just not, you start from something, but what is going to dictate if you are doing it well or not is how the patient goes.
Yes, but my own view and clinical practice is that if the patient is overweight and is older than 65 or biologically old patient, then I begin to aim it as he is overweight. And for obese patients, I also question whether the hospitalization time is the time to put off weight. Should we guide for giving less?
No.
Yeah, I think so.
So you put a patient, they might be overweight. So this is, yeah. So it's in a disuse scenario, and you're creating it. So you're trying to get this person to lose weight. So maybe you're getting them in a hypocaloric situation. So what emerges on the other side of this person coming out of the hospital is someone with sarcopenic obesity, because they'll regain the weight that they lose. The recidivism, we know that it happens, and they don't gain back muscle. They gain back only fat. So you mentioned about BMI being almost protective. That J-shaped curve flattens out after 65. In Canada, North America, and the United States in particular, there are 30 million people taking GLP-1 drugs for weight loss right now. So is that great? Is that great? I mean,
yes. Which, by the way, impacts muscle.
Yeah,
a lot.
Of course, it's going to impact muscle. So we're creating a population of people with sarcopenic obesity.
Yes.
Eventually, because they're not going to be on these drugs for life. They all want to get off them once they plateaued on their weight loss, because they lose the indication and they don't have the insurance support, and they have to buy the drug themselves.
So we should emphasize protein intake also in very hospitalized patients.
I'll never disagree with that.
Yes, thank you.
Any other question from the floor? Well, unfortunately, I don't have time, but I would like to pose a question to the panel, and maybe we can discuss next year in Prague. It has been a fantastic presentation, sets of presentations, but if you go to the supplementary material of the secondary analysis of the effort trial, particularly focusing on cancer, you will see that the improvement in mortality was achieved at much less protein and calorie intake than are in the ESPEN guidelines. So the question, unfortunately, I think we can expand the 5 more minutes. Do you believe that, first of all, we have to do what we can do in the patients? Doing something is better than doing nothing. And more importantly, do you believe there could be a different threshold by which you have an improvement in function and maybe another threshold to improve the mass? I would like to have your...
Who starts? Me, the lady.
The lady, yes.
I'm a feminist, so you can start.
Okay.
You can start, please.
Well, so you're not going to get away with me telling you that in addition to this, these people should be physically active, okay? So I'll say that for starters. That's my writer's statement. I do think that the effort trial, the advantage it has is the power to detect. It's very rare to see nutritional support affecting function without some type of physical activity intervention, but it saw it. And as you point out, you're right. The sparing in cancer patients in particular happens at lower levels. So maybe it's not necessary. I struggle reconciling that with what Carla Prado showed yesterday with the indicator amino acid oxidation method. And maybe it's active cancer that has to be supported at the high level, because after tumor resection, we know for sure that the anabolic resistance that's due to the presence of the tumor actually goes away. So there's either active cancer or with a tumor load, and maybe something changes after that. But I'm guessing, to be fair.
Yeah, well, I think it's a great question, and in the study we had goals, right? But we also said if you achieve at least 75% of the goals, starting at hospital admission where patients are sick, it is okay, with the idea that in the beginning you may not reach the goals, but then you have a stepwise increase. So I think a lot of studies have also shown now that if you try too much, too fast, it may not actually improve outcomes. And so with a strategy where you have mostly oral nutrition, in the end it's the patient's adherence and possibility to consume that is your limit. And so, in the end, the patient is kind of the one that is giving, the rate.
For the
right?
dietitian, don't be discouraged if they don't get to 35 kilocalories per kilo body weight.
Yeah. So I think in the end, we need to have higher goals, but I think we need also time to reach these goals. And it is a journey with the patient. And, if you have a little bit of time, then often you can increase. And we have seen this also when you compare the first 1 to 3 days to the later days, right? You have a stepwise increase. And I think this time is well invested.
Okay, I'm going to be a bit provocative. I'm very glad that the effort study showed impact on mortality. But I think sometimes we demand too much from nutrition alone. Although I truly believe that nutrition is therapy, going for, and mortality is an objective outcome variable, and that's why I know it's important. But aren't we demanding too much from nutrition to require nutrition to impact on mortality when we have, and specifically in cancer patients, we have the cancer, we have the side effects of the cancer treatment, be it chemo, even the new medication. So I was very happy when I saw your results because, okay, it works in mortality, but I would focus on other variables such as like quality of life, because I think to me quality of life is and it's a difficult variable to assess. There are different instruments, it's questionable and so on. But again, I think this would be ideal because nutrition alone impacting mortality is requiring too much. I know that if you do not eat, you die.
Yeah.
Okay, this is true. But the other way around, requiring this kind of therapy to impact so much on that important variable is demanding too much.
Do you think too, and we talked a little bit about this, drugs are a hammer and a nail, right? Here's the receptor, here's the drug, bang. Nutrition, there's no nutrition that is that precise and it gives you that type of effect. I don't think anyway. And so I do think maybe you're right. I think maybe you're asking a lot to say, hey, we're improving mortality. The difference is there. And I think that's pretty significant.
Yep.
I agree, but when you look at the data, actually the mortality signal is the stronger signal.
Yeah.
Yeah, definitely.
And the Nourish study, they had the primary endpoint was readmission, but they didn't find a strong effect on readmission.
When they used the two together.
But they found that mortality was actually so you're right. It is a very high goal, but the data I think suggests that you do have some mortality effects in the overall population. Now for cancer, it may also be a bit different because treatment and side effects and all that are also very important.
So let's reconcile it. So I mean, nutrition is important. It's important because we are culturally lean to help, to support, to treat, to support really the most fragile. And nutrition, maybe I agree, is not smashing on a nail, but maybe may help the hammer to smash stronger on the nail. So thank you again very much for your presence here. Thank you to Nestle.